Greetings, everyone. We would like to welcome you to our live webinar presentation, Turbocharge Your Population Health Management Initiatives with SDOH Data. Today's webinar is co-sponsored by Lexisnexis Risk Solutions.
If you were on an airplane right now, you'd need to listen to some safety instructions before the plane takes off. So buckle up and please pay attention to these brief items of note before our webinar takes off today. During the webinar, all attendee lines will be muted. To ask speakers a question, on the left-hand corner of your screen you'll see a blue Ask a Question box. Simply type in your question and press send. If you need any assistance during this webinar, please contact our Health Web Summit office at 209-577-4888.
Life as we knew it took an abrupt shift in March. Thanks to COVID-19, we've seen schools move online, small businesses close, more than 5 million people lose health insurance due to furloughs and permanent job losses, and almost 1 in 5 Americans have moved to new locations. Now more than ever, health plans need to focus on their population health management initiatives. We're pleased to welcome Rich Morino, Senior Director, Solutions Consultants, Lexisnexis Risk Solutions. Rich leads Lexisnexis Healthcare's consulting team. Over the last 20-plus years, Rich has focused on the use of analytics and predictive modeling on healthcare and non-healthcare data. Rich has leveraged this background on industry initiatives such as benefit management, performance management, cybersecurity, population health, and balancing the MLR. Rich, we're now ready for you to begin.
Well, thank you, everyone, for attending this conference, and thank you for that invitation. The overview for regards to what our topic is today. We're going to be discussing turbocharging population health management initiatives with SDOH. And as that introduction kind of highlighted, these are interesting days that we're living in right now, and it's not enough in today's climate to simply talk about SDOH within your population health initiative. We also need to address the pandemic that we're all living in. So as we get into what our agenda is going to be here, you can see we've tweaked a little bit to try and make sure that you get some useful nuggets out of how you can go ahead and apply this, not hypothetically, but in the world that we're all living in today. So we're going to spend a little bit of time talking about the tsunami of healthcare consumption on the horizon, right? When we talk about a tsunami, the reason being is before a tsunami wave hits the shore, it draws out a lot of water off the shore and feeds the wave to make it even bigger. And I often think about this right now during the pandemic we're living in. There's so many people who are avoiding care, so many people who are avoiding care who need it right now, and they're which is to completely overwhelm our finite infrastructure that can handle such demand. So we're going to talk a little bit about how that is building right now, what the trends are that are causing that, and show you some real-world examples of care that's being avoided that we need to fix. The second component, flattening that tsunami curve. You've heard the term flattening the curve. I'm twisting that definition a little bit now to talk about this huge wave of consumption which will occur post-pandemic. How can we spot the risks in that, the individuals in that, and the specific needs in that we can address right now and pull those people into our availability and address their risks and make sure their health doesn't deteriorate, so that when they finally do come in, that not only are their costs and conditions not much worse, but we prevent them from ever getting to a situation where they turn from medium risk into exceptionally high. Then we're going to give you some examples that we've seen in best practices throughout the entire industry on how to get started. Oftentimes it seems like a daunting challenge to go ahead and deploy a solution like this. And we see a lot of people out there, systems and health plans, who start to get into paralysis by analysis. So rather than boiling the ocean, what are some discrete steps you could take which make a real world impact on reducing the size of that wave we're looking at off the shore? So this is a lot of information to cover in the next hour. I'm leaving time for questions and answers. So let's go ahead and get started. And hopefully this will be some useful information you could take out into your 2020 planning and 2021 planning. The first thing we want to talk about is what is this tsunami of healthcare that I'm alluding to? So let's examine why we have this tsunami building off our coast. If you look at the graph on the left-hand side of the slide, you see research from the Kaiser Family Foundation. Now that research indicates that half the American public have skipped or postponed care. Now, given many parts of the country are on lockdown for part of our early spring, this really isn't too surprising. However, it's the next statistic that's really worrisome. 11% of the overall population reported not only skipping care, but doing so while noticing that their condition got worse. I want to repeat that. 11% of the population reported that they were not only skipping care, but they were skipping care and then noticing while they were skipping care, their conditions continued to deteriorate. That's really what's feeding that big tsunami wave right now. What keeps me up at night? Deteriorating health outcomes that were entirely preventable, but were not addressed due to fear or inability to manage them during the current COVID-19 pandemic. So prior to COVID-19, we were already aware that chronic conditions were driving the majority of our health costs. Now they inform us how many members are likely to become part of the tsunami wave if we don't act preventatively, right? Now, according to fightingchronicdisease.org, in 2020, 48.8% of the American population had at least one chronic condition. So we're inching so close to half of Americans have at least one chronic condition. Now, to the left of this slide are some of the chronic conditions that I'm sure many of you already have programs in place to help manage. Your things like your asthma, your COPD, your diabetes, your multiple sclerosis. These are all programs that traditionally our clinical care coordination and care management departments have defined teams on to go ahead and engage these members, try and make sure they manage their condition effectively and it doesn't deteriorate. It's the middle of this graph, though, that really provides a sense of urgency. 7 of 10 deaths in the United States are due to chronic conditions. 81% of hospital admissions, 91% of prescriptions filled, and 76% of all physicians visits are associated with chronic conditions. These are the people we need to make sure are not postponing their care. So often a chronic condition means that an individual is also more at risk from dying from COVID-19. Now, according to the Center for Disease Control, 94% of patients that died from COVID-19 had at least one pre-existing condition. Listed on the pie chart on the left are the 6 most common pre-existing diagnoses that have a higher risk of severe illness from COVID-19. Many of these look familiar, such as hypertension, and obesity. But let's take a look at that bucket, immunocompromised. Immunocompromised may be caused by certain diseases or conditions such as your AIDS, cancer, diabetes, malnutrition, certain genetic disorders. So let's dive into this population and see if there's any canceled or postponed care in these critical subpopulations. Now, earlier I was citing the Kaiser Family Foundation and Center for Disease Control to provide you insight into what's going on in the overall population residing in America. Now I'm leveraging research from Lexisnexis ourselves. You can see, as we talked about in the previous slide, one of the categories for immunocompromised is cancer. Now we've got this out of our own market view solution, which aggregates insights from claims in-sourced throughout the entire country. And the 4 rows on this grid represent common cancer screening activity in 2020 compared to the same period in 2019. What you see in April and May is frankly devastating. Colonoscopies were down 90% in 2020 compared to the same period in 2019. Skin cancer was down 74%, and biopsies were down 71%. This means we are flat out missing the chance to diagnose cancer earlier when the chance for favorable outcomes are better. For instance, let's look at the breast cancer information on the right side of the slide. The 5-year survival rate for women is 99% when breast cancer is found at stage 1 before it spreads. Conversely, only 27% of women survive breast cancer when it's first detected in the most advanced stage. On the last slide, we looked at common cancer screenings and observed the dramatic drop from 2019 to 2020. On this slide, we're looking to see if there's been any change in new patient diagnosis. What this Lexisnexis insight tells us is that starting in January and escalating in March of 2020, patients stopped coming in for necessary testing that would have returned a diagnosis of cancer. Breast cancer diagnoses were down by 48% in April. Colorectal cancer ones, 42%. Hematology was down 50% in May, and lung cancer was down 34%. What is especially telling is that in August, things have not returned to normal. We're still averaging 30% less diagnoses of cancer than in 2019, which is very likely not the result of Americans' health improving. And given the circumstances occurring here in our current world, we're not quite sure when this tail will finish, whether or not there'll be a second or third wave, depending on how you find it, and what is the confluence of flu season to do with COVID-19. Now, earlier when we looked at the various things which fall into the immunocompromised bucket, another one was diabetic, which oftentimes falls into our care and management list of chronic conditions that we target. So here's some Lexisnexis research on what's occurring within this particular disease state. Approximately 1 in 10 Americans currently have diabetes, with the trend increasing. At the top of the slide, we show the decrease in type 1 and type 2 diabetic diagnosis in 2020 when compared to 2019. This simply means over 1/3 less patients are coming in that would have been diagnosed with diabetes this year. That doesn't mean we have 1/3 less diabetics this year than last year. Again, it means 1/3 less of individuals who would have come in and likely been diagnosed with diabetes are not showing up, and we're not learning that they have diabetes and putting them on a protocol to treat that. The grid on the lower portion of the slides shows common tests associated with diabetes and the gap between the test utilization in 2019 compared to 2020. Particularly alarming is the testing with A1C testing, particularly alarming is A1C testing, repetitive, with the trend down 62% in April and remaining 25% down in August. Combined, this means individuals with poor health are not having the tests they need to maintain their health, nor are they coming in for appointments where a diagnosis of diabetes would actually occur. What we're viewing is a slow motion car wreck happening before our very eyes. Now this brings us to our first poll question, and that question is, how concerned is your organization with preparing for a post-pandemic surge on care? First answer is highly concerned. We are planning currently on how we might address. Second answer is concerned, but we are still trying to deal with our COVID response, so it's taking a back burner. The final response is less concerned. We are seeing a ramp up in care utilization and believe demand will naturally right itself. So I'm going to give it a few moments for you guys to all answer this, and then we'll take a look at your responses. So let's start to take a peek at what we see for responses. And overwhelmingly, 63+%, almost 2/3, we see highly concerned. We're planning currently on how we might address. So then the second bucket is less concerned. Almost 23% of you seeing a ramp up in care utilization, but believe that utilization will rightly define itself. So, we've just seen a huge swing in the polls here and live, but still almost 46% of you are saying highly concerned and planning right now. So the timing is appropriate to figure out what can we do about this. And it's probably time to turn to answering that question. Now that we've identified that the wave is off the shore, it's building steam, what can we do to mitigate it? So, when I think about that wave, I imagine each individual who is avoiding that care that probably would wind up with being diagnosis or tests as adding more feet to the size of our tsunami wave. And this wave is pulling treatable patients out of our 2020 ecosystem, and then it's going to wind up crashing onto us on a post-pandemic and a wave that's going to overwhelm our healthcare infrastructure because we really can't ramp to meet that. There's a finite amount of healthcare facilities, physicians, providers in the entire country that is not necessarily scalable. So we need to act now so that wave offshore doesn't overwhelm us. It's more manageable when it does come in at the end of the pandemic. So how do we do that? At its simplest, our message is to engage our at-risk or chronic condition patients now. Well, that's easy to comprehend. It's a bit more difficult to pull off. So the actual first step is to examine your known chronic population and determine who has no claim activity in 2020. Now, if you're already doing predictive modeling, we want to include members whose health is not yet a chronic condition, but is likely to deteriorate or turn into a chronic condition, and put them into this bucket as well. Now we have a subset of patients who represent risk if they postpone or cancel care during COVID-19. That's the first part of this equation. The next step is to determine why they might avoid care. Now, why, the question of why, is such an important part of this equation, as it's going to inform you if there's an action you could take to mitigate the member's risk. Many times there are, sometimes there aren't. Understanding that why and aligning the appropriate service to it is critical to understand how you could reduce the size of this wave. We're to get into some how we were able to go ahead and understand the why by applying socioeconomic information to the clinical information on your particular member. These two combined should present us with a population we can actively target to engage in their care during the COVID-19 crisis. Now, the last step will be to improve our ability to reach these members. Cleaning up address, phone, and email channels improves your contact rate and offers the ability to send invitations to engage your members through secure electronic platforms, which makes them more engaged in their care, more sticky, and allows further communication about how to mitigate their risks. So we just talked about on the last slide how we could focus on the part of the equation for solving at-risk members postponing or canceling their care. The next few slides, we're going to talk about that second part of the equation, right? Adding socioeconomic information to our clinical information. This should help us predict who's at risk and inform us why they're at risk, which dramatically improves our ability to develop action plans and cater their care coordination. So let's start with the story of Larry and Bill. On the left-hand side, you see Larry, 67 years old, lives in a rural residence, recently re-enrolled in his product, is pre-diabetic and has COPD. That's what clinical information tells us about Larry. And it tells the exact same story about Bill. Same age, re-enrolled, rural, same clinical conditions. Based on their clinical insights, you'd be very tempted to go ahead and say these people fall into the same risk pool and the same engagement or intervention strategy would work well for both of them. But let's go ahead and take a peek and see what happens if we overlay social determinants of health information. Now, most of you are quite probably familiar at this point with social determinants of health information, but a quick refresher. What we're looking for is information that provides us insight into these individuals and what happens to them outside the quality of care that's being delivered to them. So we'll want to know, first of all, what type of neighborhood do they live in, right? What's the value of homes there, the incomes, are there vacancies there? Is it a dangerous neighborhood? Do they live in a food desert? Which is traditionally defined by a lack of proximity to produce as opposed to pre-processed foods you might find at a convenience store. What I want to know about their ability to have access to health and healthcare. Are there even primary care physicians or hospitals within the nearby vicinity? Economic stability. What do they make a decent income? And do they have disposable income? Just because you make a good amount of money doesn't mean that you're not living beyond your ways and means, which would prevent you from having disposable income to invest in your own health. You'll also be critical to know not only about your member and their economic situation, but the household they live in and extended relatives who might be able to provide either A, positive help in the form of caregiving and financial assistance, or B, your member might be the one who has to provide them financial assistance and caregiving, which makes the pool of availability to themselves that much smaller. We're also talking about education, which is your correlation for health literacy. At what level do you need to communicate with them? Social and community context. How invested in the community are they? Are they involved in the community that might be additional caregivers? Are they socially isolated, which is worse for them than smoking, either being alone or the feeling of loneliness? It's this type of information which can provide us rich insights beyond clinical information into the risk that these two gentlemen have. So let's fill this out for them. On the left-hand side, we look at Larry. He lives at least 40 miles away from any physician or hospital. He's averaged under $25,000 in income the last 2 years. He completed his education at high school but has gotten no further. He lives alone with no family or close associates nearby who could be caregivers. And he lives in a high-crime neighborhood unfit for outdoor exercise. Conversely, Bill lives within 10 miles of both physicians and hospitals. He has significant income. He holds a postgraduate degree, and every member of his family at least has a bachelor's. He currently lives with his spouse and has 5 first-degree relatives within 10 miles. And he lives in a safe neighborhood that has, for instance, no vacant homes in the area. So now that we overlaid socioeconomic information, we see stark differences between Larry and Bill. Larry has significantly more risk than we assumed by only looking at his clinical footprint. Conversely, Bill has substantially less based on his socioeconomic status. So this really informs us about how socioeconomic information could paint a better picture about who is at risk and why. Bill, likely, we could probably maintain his outcomes and make sure that he's does okay by simply providing like a monthly postcard or email invitation for a wellness program. Conversely, with Larry, we want to look for alternative living arrangements. Ultimately, in order to get him really safe and manage his outcomes, we're going to want to get him out of there in the long run. In the short run, maybe we'll want to look at some type of food delivery service or non-emergency transportation to get him appointments that he might be unable to do so by himself. So that's the value that social determinants of health information can go ahead and provide. You know, during the story of Larry and Bill, we obviously painted a picture of contrasts. Bill will likely have all the tools he needs to manage his condition successfully, while poor Larry is going to need a lot of helping hands. However, rarely are the stories really that black and white. On this slide, you see major categories and subcategories of social determinants of health. When assessing the risk of an individual, it's best to examine as many of these as possible. For instance, a member's estimated income could be quite low today. But as I alluded to earlier, they might be making 6 figures but have little disposable income. So that would change the picture of what we look at for this individual. But the picture could change again if you see that they live in a household that makes over 6 figures, right? So we went from this person used to make a lot of money, now makes less than $20,000. That seems like it's dangerous. Oftentimes a precipitous decline in income is a predicator of future health outcomes. But then their household makes a significant amount of money. So maybe they're just no longer the primary breadwinner, right? And then the picture could change again because they live in a low-income neighborhood without access to produce. That piece of information can give us insight if we find out they don't own a car. But if they do own a car and they have the ability to drive into outside their neighborhood to buy produce, again, the picture of them as a food desert, potentially living there, changes again. Gaining access to all these elements allows us to properly understand and assess a member's socioeconomic status and which, if any, categories need to be addressed if we're going to successfully manage this member's risk. If our focus is engaging members in their care during COVID-19, then we're going to want to understand if, 1, they can afford care, 2, they have access to transportation, 3, Are they motivated to engage in managing their own care? 4, do they have access to phones or technology for remote or telehealth? And 5, are they socially isolated, or is there a potential caregiver out there that can help them? This brings us to our next poll. Does your organization currently use social determinants of health data to stratify patients? The potential answers are yes, and we've started to use it to plan our post-COVID-19 response. Next one is yes, we use SDOH data, but not specifically for this purpose. Third option, no, but we are thinking about kicking off social determinants of health programs soon. The fourth and final option, no, we do not use social determinants of health data at all. I'm going to give you guys a minute to go ahead and respond to this poll and let it fill up my queue here so we can look at the results together. And while you guys are answering that question, I'll remind you, I'm planning enough time at the very end of this to have some time for questions, and invite you to go ahead and fill out as many of those, and anything that we can't get to during the session, we'll make sure we respond to afterwards. So having said that, let's take a look at this latest survey and see what we think. So 20% say yes, you're utilizing social determinants of health now and plan to use part of your COVID-19 response. The biggest bucket, though, is the second one. Yes, we use SDOH data, but not specifically for this purpose. And that's coming in at 42.8%. So that's encouraging, because between the 20% and the 42%, we're talking just shy of 2/3 of you, maybe close to 2/3, who at least have the capacity to use social determinants of health to provide you some insights onto how to reduce the size of that tsunami of healthcare about to approach us. So let's continue on about this equation that we started, about first identifying the chronic or about to be chronic patients who haven't received care, and then overlaying the socioeconomic information on them. That's how far we've gotten. I think the next step is to talk about, well, how do we get started? So the most common mistake we see in population health is paralysis by analysis. And I think I led off the conversation at slide 1 talking about that. What exactly do I mean? Well, what we've seen oftentimes is an effort to kickstart these initiatives by examining your entire population, doing studies, geography by geography, where socioeconomic barriers to health exist, and then beginning to build out a community and social service network to address those, again, community by community. While this is an appropriate effort, it should not be seen as a sequential first step, that nothing else can be done until you accomplish that. Rather, success dictates that we do that in parallel with more discrete efforts. So take this effort in order to build out a long-term strategic assessment of integrating social determinants of health into your population health efforts. But in the meantime, many organizations have the tools necessary to start with more discrete deployments that can make an impact on reducing the size of the wave right now. Good example of that are health plans that have entire teams focused on clinical quality and clinical quality scores. Now, whether you call it, whether it's HEDIS or STAR or what have you, oftentimes these teams already have some social and community services set up in certain communities, and those could be leveraged immediately. Apologize. I want to make sure that I'm not talking before the slides have a chance to advance. So how do you pull off an entire population analysis but spot areas where you could start more discreetly? Now, this analysis overlays 2 different risks. Motivation to engage in one's own care is on the y-axis, and medication adherence, the likelihood of filling 80% of your scripts, is on the x-axis. The result allows us to form a kind of a stoplight of analysis on which members represent little risk, which are represented in our green buckets, as well as which represent a lot of risk, represented in our right buckets, that will take a significant engagement effort to address and mitigate their risk. In the middle are the yellow bubbles. These could represent movers. I'm doing that in quotations, I realize you can't see, so I'm describing it. Our air quotation movers are those who have some risk, but might be brought into compliance or closing their gaps if you can align them with a social or community service to mitigate that risk. Usually one might do the trick for this movers bucket. Since we've now identified that they're a risk, let's look at the ones that we'll be able to assist them with in the short run. Earlier, I mentioned that many health plans and health systems already have some social and community services, and they've been historically coordinated through care management or clinical care coordination. However, if you don't have those in place, or if they're unavailable, there are always other options. The company Lyft, for example, has contracts in place with over 20 states to provide non-emergency transportation services to the Medicaid population. Many health plans provide smartphones to transient populations to make sure they could be reached to coordinate their care. Now, during our current pandemic, this has a double benefit for those at risk, right? Because not only do they have a phone now where you can communicate and send text alerts to remind them of opportunities, but you could utilize that smartphone to engage in telehealth, as well as let them download your app, where you could go ahead and see results of tests and labs and communicate with your provider efficiently if they also fear going into the physician's office during this pandemic. So taking a look at this particular slide, you can see that there are lots of different options that you could go ahead and start to build out in discrete communities rather quickly, whether it's alignment and coordination with food pantries, whether it's the non-emergency transportation, which could take care of socially isolated individuals who are lacking transportation, whether it's medication adherence and getting them involved within the food coupon programs, right? So, I'm sorry, the medication programs, discount programs. So there's a lot of different levers you could pull in a relatively quick environment that you could enact while you're building out your complete population health management project and timeline that includes how to address the green and the red. In the meantime, you could still go back and find those easy movers in the yellow. So let's circle back to the story of Larry and Bill and assume you had Larry from our story as your member. We know he has COPD and he's pre-diabetic. Now we also see that he lives in transient housing, has no car, and lives in a dangerous neighborhood. Ultimately, we may want to address his housing situation, but that's an effort that will take some time. In the short term, we could sign him up for food delivery from a social service like Meals on Wheels. This will prevent him from eating only processed foods that could turn Larry into a type 2 diabetic, as opposed to keeping him in pre-diabetic status that he is right now. So we talked about social determinants of health and population health management, how there is a long-term play to observe your whole population, but there's a short-term play to identify those at risk right now, understand why they're at risk, and begin aligning programs right away. The final step, once you've identified this population and want to engage them, is frankly a simple one, and that is cleaning up the contact information you have. So at the top of this slide, you can see questionable starting point, and this is information that we got from Boston Consulting Group. And it shows by line of business how accurate is the contact information for your members based on line of business on day one. So open enrollment is concluded. You get the final enrollment packages to you. Congratulations. If you are managing an employer-based book of business, 15 to 20% of that information isn't accurate on day one. It's much, much, much worse if you're doing managed Medicaid. You can see 40 to 50% of contact information provided to you on day one is inaccurate. Now, this has obvious ramifications for us in regards to trying to reach out and coordinate our patients' care. And if I did this correctly, that's just the starting point. That information erodes quickly. Here at Lexisnexis, we calculate that there is over all the people who reside in America, the contact information changes 3% a month. So that means if we ignore this questionable starting point and pretend when you get your open enrollment file for contact information, if it was 100% accurate, within 18 months, it will now be only 50% accurate. Why is that happening? Well, about 45 million people move about a year within the United States. We see 3 million changes in marital status. Almost 4 million children are born annually. 2.5 million people die annually. Plus, there's 21 million employment changes that we see every year. So there is a big need to go ahead and verify the information you have is still a channel which you could reach and engage these individuals. So if you don't address this, unfortunately, we deal with situations like this. So earlier we were talking about the gap that's occurring between 2019 and 2020 and people coming in, women coming in for mammographies, and what that might mean if we're unable to catch it at stage 1 as opposed to advanced stages. Here's a story for, I could tell you, a managed Medicaid plan where we're taking a look at their ability to contact these individuals. So, you know, the breast cancer screening, we're targeting women between the age of 50 and 74 who had some evidence of mammography in the past. And what we saw in over a 20,000 person file, 34% of the time, the open enrollment or supplemental enrollment phone number that was supplied to this managed Medicaid plan would not have reached the individual. And 44% of the time, the address wouldn't have been good either. So if you're trying to send them an invitation to come on in or a reminder postcard, what have you, it would have never reached this individual, which dramatically lessens the chance of you being able to engage them and get them in for these preventative screenings. Similarly, here's some results from a colorectal cancer screening, right? We're looking at members aged 50 to 75, and we'd seen 31% of the phone numbers weren't there, and 40% of the addresses were wrong. In addition to 40% of the addresses being wrong, 4,000 people from this pool that we analyzed no longer lived in that state. So if they were managed Medicaid or certain commercial products, that has large ramifications, not only for treating them, but also where their coverage and payment should come from. So the key to reducing the wave of the size, the key to a tsunami and reducing the wave that's ultimately crashing on our shore right now is to reduce the amount of people we are being dragged out into shore and becoming part of that wave and pull them back into our infrastructure today. If we could do this effectively, what will occur is when that wave happens and hits the shore, which is COVID-19 pandemic finally being over, we don't have this huge repository of pent-up demand from individuals, especially those at risk, which are going to overwhelm our resources and lead to these people's outcomes being so much more worse. The solution to this is targeting the people not coming in for care who have chronic conditions and have socioeconomic barriers to solving those during this COVID-19 pandemic. The final leg is once we understand who is in this population, who's at risk, and why they're at risk, and we can align a resource for it, now we want to be able to go increase our chances for reaching them and remaining sticky with them during this pandemic. Having articulated, hopefully, that equation in an effective manner, I think that concludes this presentation portion. And now I'm going to pop open the questions and see if there's anything that I can perhaps answer for you. So the first question I see here, thoughts on tension between healthcare providers doing more for poor older patients versus fraud and abuse anti-kickback. It's not that hard to look visually at a consumption of healthcare and see that a disproportionate amount happens within the elderly population. So I think from an aspect of targeting them, you will see if you overlaid socioeconomic information that age is a major indicator of that. Matter of fact, one of the things that we see in making predictions around readmission risk, for instance, is not only if you are old and socially isolated, but if you also live with someone who is elderly, defined as 80 or over. The stress of being the caregiver to them, as well as the drain on your finances of being their caregiver and having them reside in your house, also is a very large indicator. And in regards to fraud and kickback, anti-kickback, not positive where you're going. I'm guessing that has to do with long-term care, elder abuse type stuff. I won't get into that, but I will see that another major indicator of when we talk about age and we talk about long-term care and skilled nursing facilities is how many times they've been in different skilled nursing facilities or assisted living facilities. That's something to keep an eye on for two reasons. One, the reason you alluded to here around potential abuse. But the other is if someone consistently is going in and out of skilled nursing facilities and assisted living facilities from one to another, there is a high correlation from them to being readmitted to the hospital or being a frequent flyer for ER. But the reason being is that there's no one place they have lived at that has the institutional knowledge of all their problems. So those aren't being treated in the new facility in time for them to make an impact before you revisit the hospital. So hopefully that answers your question. If there's more to the fraud, abuse, and the anti-kickback that you'd like to explore, I'd be happy to do it. Please put in the question again. I'll try and get to that. Another question, will we get a copy of these slides? I believe the answer is yes. This deck will be available for download at the conclusion of this meeting. I know that we've provided authorization to go ahead and do that. Next question. When generating risk scores, actuaries typically use cost as a response variable. Thus, we use cost, which is subject to its own market forces, as a proxy for overall health. What advances have been made using machine learning inputs to predict some indicator that is more equitable to health? And that's an excellent question, and there are obviously cost forces throughout contracts between payers and providers change throughout the entire country, right? And it's not as intuitive as you might think. Oftentimes, healthcare costs are a lot higher in markets where obviously there's a monopoly in regards to the health system, as opposed to an area like, for instance, New York City, where you would think the cost would be very high, but due to so many options, there's more competition. So the question then is, what advances have been made using machine learning inputs to predict some indicator that is more equitable to health? I will tell you that rather than focusing on costs, what we've been doing is focusing on the risk side of the equation. So what individual, obviously estimated income means something different if you live in Paducah, Kentucky than if you live in San Francisco, right? So there has to be some regionality as far as your estimated income and your financial health in regards to where you live. I guess I'd answer the question this way. Here at Lexis, we are in the identity management world, and we keep track of over 400 million living deceased individuals who have resided in America, as well as 50 million active and inactive businesses. And what we do is provide within our logic some information that allows us to understand your context for where you lived and where that is, and set up essentially what does that income mean for the region you live in, or what does that cost mean for the region you live in, as opposed to others. So you do want to have some regionality in it. I fear that I'm about to go down a deep hole into how to develop models and how to tune machine learning. And I don't want to necessarily get into that now, but I do see the contact information for the person who answers this question, and I'd be happy to get into a separate session to go into more details about that. The next question is in regards to poll number 2. What purposes do organizations use social determinants of health for not for this purpose? I think with that one, we were specifically asking, are you looking to try and utilize social determinants of health to identify particularly at-risk patients who will not be engaged with health during this crisis, right? So it's the particular use for trying to build a targeting model that will sit there and say, this individual is most likely to not be engaged in health until COVID-19 is over, due to the fact that they, for instance, lack internet and are socially isolated so that they wouldn't have someone who could bring that to them. So how do you target those people to get them engaged now, as opposed to the more general purpose of social determinants of health, which is to provide additional insight into who's at risk, and then provide that more critical component, I would argue, than who's at risk, with the why they're at risk, which really turbocharges the efforts of your care coordination team in regards to developing our action or intervention plan. Next question, do you consider the social determinants of health data that you have public use data? Have you encountered issues with privacy concerns by patients or research subjects with the use of this data? That's an excellent question. The answer is complex. The social determinants of health data comes from a variety of different sources, and I'm not going to just talk about the Lexisnexis, I'm going to talk overall. Social determinants of health data could come from physicians in the form of ICD-10 Z codes that they ask from their patient engagement. It could come from census information, or Robert Woods Johnson Foundation, which we see is useful for one of those 5 major categories of social determinants of health, which is assessing what the environment is in their neighborhood, but it's not specifically attached to them as a member or a patient. So that as an additional source. There is information that could come from, such entities as marketing companies. Does Rich Morino have a subscription to Men's Health magazine? And if so, what does that mean? Does it mean that he's healthy? Does it mean that he's unhealthy but aspires to get himself in shape? Or does it mean that his family is about had it with him and they're bought this for him in order for him to take the hint? So there's all sorts of information like that might come. And then there's data that comes from what we call regulated sources. Some data sources are particularly good and useful, but might fall under federal regulation for their use. For instance, the Graham-Leach-Bliley Act. So the reason I tell you all this information is it's critical when you assess your social determinants of health needs to find out what your use case is and match the right data with that. For instance, if you want some of that rich regulated data, you have to make sure that you are partitioning that information on off and only using it for the clinical care improvement use case, not for anything else. So there's a world of social determinants of health data available. Some of it is public use data. Some of it is much more regulated, can only be used for certain instances, specifically due to privacy concerns. So again, we have here at Lexisnexis, we've partnered with EHI. There's an entire collaboration being done by such entities as the American Medical Association, AHIP, HIMSS, and so forth, which have laid a groundwork for rules by which social determinants of health should be used and the standards by which it should be held to. I believe it could be found at the EHI Ethical Use of Social Determinants of Health. I think my contact information will be included at the conclusion of this, and I'd be happy to go ahead and provide links and materials on that should you want more information on that. What data sources do you use for social determinants of health information? How much of this is member level? Excellent question, which we treaded on in the last 2, but not going in specifically to. There are 3 types of levels of social determinants of health information. The first level is essentially neighborhood level information, and that's your census or Robert Woods Johnson Foundation information. The second level is member level or patient level, depending on who you might be. So this is information that's tied to the individual. It can be inclusive of neighborhood information, but that's where you start to get some of your estimated income, wealth, whether they have transportation, and they have a car, whether they're close to healthcare, whether they live in a food desert, that type of information. We found that in assessing an individual as opposed to assessing an entire population, having information tied to this individual is critical. I'll give you an example. If you live in a gentrifying neighborhood in an urban location, right, and if I were only to look at census level information, what I could infer is that an individual lives in a neighborhood with a high amount of Section 8 housing, a low income and property value overall, and likely in a food desert. However, if that person bought a luxury condo 3 doors down from Section 8 housing because they realized the neighborhood's getting ready to change, they drove a big SUV and they could drive 1 or 2 neighborhoods away to buy overpriced produce at a Whole Foods, that dramatically changes the picture of this person's socioeconomic status. So having that member level data, if you're trying to predict individuals rather than populations, is critical. The third thing I would advise is if you're looking for social determinants of health data, to try and avoid receiving a data dump. Since so much buzz about social determinants of health out there in the world today, anyone who has information about an individual is now trying to package that up as social determinants of health. Here at Lexisnexis, we're trying to help define the market and saying that a social determinants of health data point should be already going through some form of statistical correlation analysis to show it's related to a health outcome target, so that it's useful in predictions around the total cost expenditures for the next 12 months. They can identify how much pharmacy service you're about to consume, your motivation to participate in care, the likelihood of you becoming a frequent flyer in an emergency room, using it 3 times or more, or the likelihood of you having an inpatient stay, for example. If it doesn't have a good correlation to one of these outcomes that can be proven through a correlation analysis, it probably should not be included in any package you provide to an analytics team to develop their own predictive models, or included in any model that's built itself to try and understand and align services to an individual member. The next question I see is, do you have any data and recommendations on tech literacy and its impact on the use of telehealth virtual care technologies? That is an excellent question. Most of the time what we see are 2 different functions, or 2 different initiatives to try and address this. One is frankly drawing a line and trying to say that education is a correlation for health literacy, and that the more education an individual has, the more likely they're able to understand the importance of healthcare, as well as their ability to understand information you might be able to provide to them. The tech is the more interesting aspect. What we traditionally see right now is the need to see whether an individual has a cell phone, smartphone that they can interact with, and there's starting to be examinations on how you can gain access to insight into whether or not someone has access to internet or broadband as well. So I think that's probably be something that the industry solves for in 2021. It's very much on most people's roadmap right now. I will provide these slides. Another question we got that will be available if you guys. I'm not certain how quickly that'll occur, but I do know that once this process is forward, these will be generally available. Next question. Many of the standardized SDOH questionnaires are cumbersome. Do you have any thoughts about a single question that would help direct the case management to their social needs? There's a couple different questionnaires out there, sets of questionnaires. They are somewhat cumbersome. The thought process with them is, how can I find innocuous questions that I could ask an individual which will not alienate them, but will provide me the insight in regards to how I should develop an intervention program for this individual. What I would articulate is, for those who used to watch the show House, medical show, he always says, well, everyone lies. I wouldn't go so far as to say that, but the problem with questionnaires is how many people are really honest about how many glasses of alcohol they have in a week. Here at Lexisnexis, we've worked with some health plans and health systems, and we'll find out that an input address a patient had provided or a member provided is actually a vacant plot of land. Now, what does that mean? It probably means that the individual has housing stability problems and was too embarrassed to tell you that. So what we recommend is getting some type of objective third-party information that can provide insight. Now, you never want to provide to the clinical case manager, all this information about the individual. You provide them specific insights built off your analytics. So, for instance, this particular individual might have address mobility issues. So, that will be the cue for you to develop a question from your case manager is there a great place for us to have these medications shipped to? Or would you rather have, come in to pick up yourself? And if you want to have it come to pick it yourself, is getting to the pharmacy going to be an issue, or would you like for us to have some help in coordinating your ride? So it's identifying the information that can provide you good insights is the first step. Second step then is to pick out what piece of information is appropriate to provide to those case managers. And the third is developing the innocuous question, which you can use your prop errors of the world, for instance, if you want to, or develop your own, which will allow the case manager to ask a question of this individual, this patient or member, which would extract from them, a yes, I wouldn't mind that service, without making it seem like you are big brother or that you are intimately familiar with their socioeconomic status. It needs to be phrased in a manner that shows that you are sitting there and asking this question just to make sure that you have all the appropriate insight necessary to help them manage their care. So I think that brings us to the end of most of the questions we have here today. I want to thank you all for spending some time with me here for this particular session. I hope you find it useful. And any questions that come up after this, I'd be happy to answer via email. Having said that, thank you for your time, and this concludes today's presentation.